Now we're going to talk about resistance against the microbes, and this picture shows you some of the mechanisms, not all of them. So without even looking there, let's imagine for a second we are all microbes and we're being treated, we're being attacked by the drugs. What would you do to make sure that you are not killed by the drug? What would you do? How can you overcome the lethal effects of the drug for you? You're a microbe, remember that. Be more specific. What enzyme? What enzyme should do? You're on the right track. Go ahead. Okay, so if drug inhibits the cell wall synthesis, then make sure that cell wall is so abundant that it doesn't affect it. Is that what you're trying to say? Like, make a lot of cell wall, quote unquote. Not for the cell wall, but it's the mechanism. Overcoming the effects. Okay? So if the drug inhibits a certain pathway, make this pathway so fast or so numerous that the inhibitory effect is really minimal. Okay? Overproduction. Okay? What else you can do with the drug? Come on, what you can do against chemical warfare? Chemical weapons, what you can do with them? Did you not see the apocalyptic movies? Come on. What people put on when there's a chemical attack. Thank God. I thought I was the only person who grew up in the Cold War. Gas mask. So prevent chemicals from getting into you. Can a microbe do that? Sure. It can prevent the drugs from getting into the cell because, look, if they need to inhibit ribosomes, if drugs inhibit ribosomes, unless they're in the cell, there is no way they will inhibit them. Does that make sense? So prevent the entrance of the drug, prevent the penetration. You can see it here. Okay. Sorry about that. Okay. Once it's in there, if somebody is poisoned, like when you're really drunk, what is the best way to reduce the symptoms of hangover next morning? Vomit. Okay, so get the ethanol out of the, at least, well, not the entire system, but at least stomach. Okay? So efflux pumps. Special proteins that pump the drugs out. Right? Can you destroy the drug? Why? You're a microbe. You can do whatever you want. You can. Beta-lactamase. Remember beta-lactamases? The enzymes that destroy essentially beta-lactams? There you go. You can destroy the, destruction. Okay. Destruction of the drug. Now imagine this. If you have a drug that inhibits ribosome, because ribosome is a certain structure, what's going to happen if you slightly tweak the ribosome structure? The drug becomes not as effective. Do you see what I'm trying to say here? If you modify the target for the drug, then drug is not effective anymore. That's another strategy. That make sense? So this table summarizes drug modification. That's the beta-lactam. Beta-lactamases chemically modify the beta-lactam rings and render drugs like penicillin, ampicillin, methicillin, fortunately carbapenems, inefficient. Okay. Prevention of cellular uptake. Less drug enters the cell. Pseudomonas aeruginosa, which is known for its absolutely notorious antibiotic resistance, produces the protein called porin and allows drugs to get into the cell. Some strains of Pseudomonas decrease the number of those porins, reducing the amount of drug that can enter the cell. Okay. Pumps. Efflux pump that pumps the drug out of the cell. Okay. Modification of the target. Again, going back to beta-lactams that we talked about, right? Beta-lactams bind to which protein? Do you remember? Penicillin binds to penicillin binding protein, right? If you modify the target site of penicillin binding protein, then penicillin cannot bind to it anymore. This is called target modification. Does that make sense? We modify the target for the drug. Target overproduction. Remember sulfa drugs, sulfonamides. They are competitive inhibitors of one of the enzymes in the pathway for the folic acid synthesis. If you produce huge amount of that enzyme, drug will inhibit some, but you will have enough uninhibited enzyme left to carry out the folic acid synthesis. Does that make sense? See what I'm trying to say? Enzymatic bypass. If there is any way, say, let's put it this way. So you have certain sequence of steps, okay? Compound A is convert compound B is convert compound C, convert compound D. If your drug inhibits this step, microbe may evolve to go through, say, B prime, B double prime, and eventually C. So it kind of gets around the roadblock. Does that make sense? Can develop enzymatic bypass. Finally, target mimicry. That's actually a pretty cool strategy. Drugs like fluoroquinolones bind to the DNA gyrase, the protein. Mycobacterium tuberculosis produces peptides that can also bind to fluoroquinolones. Does that make sense? So the drug will bind to the decoy instead of binding to the actual enzyme. The decoy essentially depletes the drug, the available drug, and there's no effect. Does that make sense? Do you understand what I'm trying to say? So the 6 strategies here, 7 strategies. Now, to which level you have to know them? You have to be able to recognize which strategy I'm talking about. I'm not going to ask you to provide examples, but if I tell you hypothetical microbe A produces the penicillin binding protein that has modified penicillin binding site, so penicillin is not effective anymore. This is target modification. Pseudomonas aeruginosa produces enzymes that can destroy aminoglycosides like streptomycin or kanamycin. This is drug inactivation or drug modification. Does that make sense? So you have to know these 7 strategies. Am I clear? No examples, no worries. I'm not going to ask you, what are the main mechanisms of resistance by Pseudomonas aeruginosa? God forbid, we don't discuss it. Okay? Clear? Before we get to this fairly boring slide, I want to really go back and talk generally about antibiotic resistance. It's actually a great opportunity to discuss an important topic. Where does it come from, antibiotic resistance? What drives antibiotic resistance? Huh? Yeah, the exposure to antibiotics. Why? The adjective. Selective pressure, right? Selective pressure. Those microbes that are not resistant to antibiotics die. It's actually a good, somewhat sobering thought about evolution. All the species that you see around, including yourself, I'm not species, everything living that's around are the things that survived. Everything else died. Okay? Same goes for microbes. When exposed to antibiotics, they either die, or if they're resistant, they will become dominant part of the population. The resistance, initially, so resistance that we observe in clinically important microbes, where does it come from? Can it be intrinsic, like can it exist in the bacterial population before we use antibiotic? Yes, before we use. Because this antibiotic, especially if we talk about, bless you, especially if we talk about natural antibiotics, okay? They were out there for millions of years. So microbes already have the resistance. What else can drive the resistance? What is one of the major driving forces for evolution? Yeah, mutations, of course. Random mutations. So random mutations will drive the evolution. That makes sense. Now, in order to prevent the resistance, how can you use it? Which antibiotics are more likely to promote the resistance? Broad spectrum or narrow spectrum? Broad. Why? You're right. Broad. Why? Yes, you have more species put under the selective pressure, so you have to consider. If something is broad spectrum, it usually acts equally mediocre against everything, right? One size fits all, usually it's a lousy fit, okay? So narrow spectrum, when antibiotic is very targeted, it works great on a certain microbe, but doesn't affect anything else. When you have, say, tetracycline, it may kill all the gram-negatives, I don't know, Haemophilus influenza, gram-negative infection of the gum, okay, the gingival infection, okay. You treat with doxycycline because those are probably gram-negative. Anaerobes like treponema but you also affect all kinds of stuff all over the body. Okay, and that all kinds of stuff start to develop the resistance. Okay, so broad spectrum should be prescribed only when you have no idea what's going on. What else drives the resistance in clinical settings? Non-compliance. When you get a prescription for, I don't know, like 15 pills, and you're told 2 pills a day until you're done. Not one, not 15 days for one pill a day, but 7.5 days, 2 pills a day. There's a reason. You got to maintain certain concentration, so that certain concentration does what to microbes? Kills them. You don't want any survivors, right? Does that make sense? So this is often called an antibiotic stewardship. The responsible prescription of antibiotics and responsible use of antibiotics. You have a flu, influenza, and you go to the doctor. Should you take antibiotics? Should you be prescribed antibiotics? No, influenza is not a bacterial disease, it's a viral disease, right? Antibiotics are not effective against viruses. What's the problem with that approach? It's sociological, it's not medical. Say again? There you go. They want a pill. Okay, I come to the doctor tells me, dude, go home and suffer. In 5 days you're going to be better. I don't like that doctor. I want something that will fix me up. Okay? Does that make sense? So, if doctor doesn't prescribe me a pill, what am I going to do? First I'm going to go to Yelp. Or, what is that? Reviews for doctors. And I will leave like horrible review because I didn't get the pill. And then I will go to another doctor who will prescribe the drug just to make me feel nice and to keep the practice. That's a big problem. So we have to educate. Your part of your job as the healthcare professionals is not only to treat the patients, but to educate them, to tell them what's going on. Why you do not prescribe antibiotics. In some cases, it's a good reason just to say, look, you probably have a bacterial infection. Okay? And, common signs of bacterial respiratory infection is green sputum and green nasal discharge, right? Because it's a purulent nasal discharge. So if you have a patient who came to the practice with purulent nasal discharge, don't tell this patient that he has allergy. It's a bad excuse. Tell the patient, look, most likely in 3 or 4 days, you're going to be better. You can give antibiotics, it can mess up your intestines, and it will probably reduce your recovery time by 12 hours. That is true. The study shows that the use of antibiotics in ear infections reduces the recovery time by 12 hours. So it's not really justified to use antibiotics against ear infections. Most ear infections, they resolve by themselves. Okay, but it's large clinical studies. We will have a chance to talk about differences between the clinical science and actual medicine, how physicians see it. Okay, so you have to educate patients about being responsible, being compliant. One of the greatest sources of antibiotic resistant microbes, I have to probably make a disclaimer, it's not a chauvinistic statement, it's life, India, and to a less extent China. Okay, why India? A lot of people in India, there are a lot of doctors, and as some even Indian fellows say, those doctors are not at the professional level of like MDs here. Okay? So when people with disease such as tuberculosis come to the doctor, normal doctor, good doctor will tell them, look, the treatment is going to take 2 to 4 months. You have to religiously take drugs every day. It's going to be a cocktail of drugs, and we're going to constantly test you to make sure that, you know, the bacterial load goes down. It's expensive. So what happens often, oh, have tetracycline, take it for 2 weeks, you're going to be fine. And surprisingly, in most cases, yes, people are going to be fine. Meaning, they're not going to have any symptoms. They're still going to have mycobacteria, worse, mycobacteria that they incompletely treated 2 weeks is going to become resistant. Okay? So, irresponsible use of antibiotics in clinical practice contributes a lot. Not so much here in the States, but my home country, I can buy a ton of different antibiotics over the counter. It's not a problem. China, same. India, prescription, but getting prescription is not such a big deal. Okay? But perhaps it's not the major driver for antibiotic resistance. What is? Which human activity is the major driver for antibiotic resistance? No, we don't clean with antibiotics. No. Farming. Poultry. Mostly poultry, because we produce so much chicken. There was a study in the Netherlands, I may have mentioned it, and they traced down the penicillin-resistant, methicillin-resistant Klebsiella to methicillin or penicillin-resistant E. coli in chicken. It turned out that pathogen that was causing the disease in humans acquired the gene from E. coli that was causing the disease in chicken, and that E. coli evolved in chicken because of constant penicillin use. And the thing is, the treatment of farm-raised animals like poultry and cattle and pigs, it is not, oh, we have a sick animal, we're going to give the sick animal antibiotics. No, antibiotics are given over practically entire lifespan in the low doses, because it was shown that use of antibiotics in that manner increases growth. Probably, you know, blocking like a small maladies. But it also drives development of antibiotic resistance like crazy. I don't know about all European countries, but in Netherlands, partial after that paper, they completely banned the use of antibiotics in farm-raised animals. But nevertheless, it is already out there. MRSA, which first appeared in the beginning of 2000s, was considered to be a pretty bad bug, right? Now more and more clinical microbiologists suggest that it's a new normal. Just have Staph aureus, which is resistant to methicillin, so we have to live with that. It's normal. It's fine. You have to find other ways to treat it. That makes sense. Now we can go to drug-resistant bacteria, and sorry, it shouldn't be resistant to. I will tell you what. It's another study tool here. So this table up there is, I provided, actually stands for, it should be stands for. Okay, stands for. For the exam, you have to know the acronyms. I may ask you, which one of the following acronyms is enterococcus? Which one is staph? Which one is whatever? Does that make sense? So MRSA, you know that, methicillin-resistant Staph aureus. Okay? I'm not going to put resistant Staph aureus. You have an idea how to spell it out. Okay? It is resistant not only to methicillin, but to a variety of beta-lactams. Okay? And the main mechanism is target modification. Penicillin binding proteins of MRSA have low affinity to different types of penicillins. So penicillins do not work on them as well. Good? Cool? Okay. You're going to find them. Hospital-acquired infections. A lot of it is in there. Also, community-acquired infections, you can get them just, from other people. Frequently causes pneumonia if it becomes septicemic. It's really bad because Staph aureus produces a variety of virulence factors, and staphylococcal septicemia may be very quickly lethal, causing septic shock. Okay. Now, VRE, VRSA. Vancomycin resistant. E stands for Enterococci or Enterococcus. Okay, vancomycin resistant Enterococci. What is VRSA? Vancomycin resistant Staph aureus. Vancomycin was used to treat MRSA. Now we have VRSA. Now, vancomycin resistant Enterococci are also common cause of hospital-acquired infections. Enterococcus is the gram-positive microbe that can be found in the human intestinal microbiome. So you can imagine when patients received vancomycin as the treatment for various bacterial infections, Enterococcus present in the intestine evolved to become resistant. Now, in your gut, it doesn't cause anything. But when it gets out of the gut, and it definitely will, when people defecate, people, due to the not 100% hygiene, it's going to end up in different parts. It causes a lot of problems, especially in the sphere of wound infections and different types of septicemic infections. So generalized septicemia and infections of the skin wounds. Does that make sense? So you got this. ESBLG minus. That's a mouthful. Now I'm going to try to write down extended spectrum beta lactamase gram negative. Okay. Bless you. Does that make sense? So, what is beta-lactamase? So, beta-lactams, okay, excluding carbapenems. So, the latest generation carbapenems can be used to treat these infections. Other than that, they are resistant to cephalosporins, to monobactams, to penicillins. Okay, extended spectrum beta-lactamase. So the enzyme that breaks down beta-lactam ring has the extended spectrum of activity. Does that make sense? The microbes that can be found in that group include Pseudomonas aeruginosa, E. coli, Klebsiella pneumonia, Salmonella typhimurium, and so on and so forth. All kinds of common gram-negative pathogens that are associated either with the digestive tract or some of them with the respiratory infection like Klebsiella and Pseudomonas. Of course, they contribute to hospital-acquired infections. Okay, to a great extent. The problem with these guys is that often the genes for beta-lactamase are present on the plasmid. And if they are present, these genes are present on the plasmid with other resistance factors, like resistance against aminoglycosides or fluoroquinolones, you get not just extended spectrum beta-lactamase gram-negatives, but so you get microbes resistant not only to beta-lactams, but also resistant to some other drugs. So you get extended drug resistance or multi-drug resistance. Does that make sense? CRE. That's really scary one. CRE stands for, wait a minute. Carbapenem resistant. Now brace yourself. I'm going to write down the name of the bacterial family, I think. May I just go over here because it's going to be a mouthful. Enterobacteriaceae. Yeah, I think that's enough. Yeah. Enterobacteriaceae. You will not have a task to spell it out. Don't worry. Okay. So Enterobacteriaceae include microbes that can be commonly found in the human digestive tract. Most notably, things like E. coli or Enterobacter aerogenes or Klebsiella pneumoniae. Now, why it is so scary? Because of what they are resistant to. It's carbapenem. Different types of carbapenems. Okay. And one of the most recent unfortunate discoveries from that group, bless you, was Klebsiella pneumonia, that was found to be resistant to carbapenems, was found in India. India again. Okay. People got alerted, but let's admit one thing. The United States isn't majorly concerned about anything except the United States. So, okay, you guys in India have it, well, too bad. Well, guess what? In a couple of weeks, the same microbe was found to be a causative agent of pneumonia patient in the United States. And it was not imported case. It was a toxinous case that originated in the States. So now we have this microbe, mostly in different hospital populations. It is not very frequent, but it's present here. And it's really hard to treat because its resistance is probably the most effective antibiotic that we have. That makes sense? And the culmination, the climax here, MT. Any idea? Rifampin isoniazid. What are they used to treat? Specifically, these drugs are very good against this particular microbe. Yes, it's Mycobacterium tuberculosis. MT stands for Mycobacterium tuberculosis. MDR, XDR, TDR. What does that stand for? If you talk about resistance, then R stands for resistance, D stands for drug. Now, M, X, and T. Multiple, extensive, and total. There are strains of Mycobacterium tuberculosis that are resistant to many drugs, most of the drugs, and all of the drugs that we have. And I don't know about you, but it scares the shit out of me. I am serious. Okay? Mycobacterium is the microbe that's really easy to acquire. It doesn't really cause infection in all people that it infects. About 5% of people who are infected develop the infection in their lifetime, the clinical disease in their lifetime. But here's the problem. First of all, what is the transmission route for tuberculosis? How people are airborne, yes. It's respiratory, right? It's really easy to transmit. You don't need to do the blood transfusion, things like that. Okay? Which means you can wash your hands all you want. If somebody coughs next to you, you can get it. Okay? Source of total drug-resistant tuberculosis is India. For that particular reason that I described just before, the non-compliant treatment and non-compliant use. Okay? People don't give the enough antibiotic in the first place to treat, and whoever takes it, it's not necessarily finished the course of treatment. It was a case when a person was found to have active tuberculosis infection, and the strain was determined to be total drug resistance. And the patient was strongly advised not to go anywhere, while infection is being treated. Instead, the patient went to attend the wedding of his brother in India and then flew back to the United States. So they had to test how many planes he took. They had to test every person in those planes to see if they acquired TB. Luckily, nobody did, but it was a pure luck. Okay? So how do you treat such things? Use combination of drugs. You can treat total drug-resistant Mycobacterium tuberculosis. It takes very long time. It takes increased amount of drugs, increased dosage of drugs, and therefore patients have much more severe side effects. Does that make sense? So you can treat. It's probably one of the most pressing issues in public health now, development of more and more drug-resistant strains of tuberculosis. Okay? Now, so for these guys, for these acronyms, know what they are resistant to and what they are. Does that make sense? So if I ask you, which of the following is enterococci, you have to recognize that it's going to be VRE. Okay. Which of the following is tuberculosis, you have to recognize that it's something with MT. Right. Now, how do we test the effects of antimicrobial drugs? We just did. It's a Kirby-Bauer test. That's what we did. That was a Kirby-Bauer test. Okay, so you drop the discs infused with antibiotics on the bacterial lawn of a certain microbe and measure the size of the inhibition zone. The bigger the zone, the more effective antibiotic. Does that make sense to you? Very good. Because this method has a significant disadvantage. Do you remember which one? No. I'm talking about antibiotics. Antibiotics. What is the disadvantage of using discs infused? If I say next phrase, it's going to be the answer. Look, I'm all for human experimentation. I'm all for it. It's not considered ethical, but I'm all for it. What about the concentration on the disc? Just one concentration, right? You cannot vary the concentration. Of course, it is clinically relevant concentration. It's not just some random one. But still, it's kind of inconvenient because sometimes you can steer away from the concentration, the dosage that recommended, okay? What if you double the dose? What if it'll become effective? Maybe in some cases you have to do that. Does that make sense? So, advantage, it's fast and convenient. Disadvantage, the fixed dosage. You can do dilution tests. Essentially what you do, you progressively, like on this picture, you increase the antibiotic concentration from, say, like on this picture, 2 micrograms per ml to 32, so you double. And you can see at which concentration bacteria do not grow anymore. So you can say that at 8 micrograms per ml, it doesn't. At 4, it does. So you narrow down the interval, the range, right? So it's somewhere probably between 8 and 4, and you can further narrow it down. Does that make sense? Dilution tests, or like the one that is present over here, okay? So you can see that it's a low concentration of antibiotic on the left. I'm talking about the picture number 2. High concentration on the right, okay? So as concentration elevates, you can see that growth, which is shown like a orange or yellow dot in the center of the well, growth disappears, okay? So for instance, here it disappears, okay? Here it disappears, here it disappears. The moment the lowest concentration of antibiotic that inhibits the microbial growth is called minimal inhibitory concentration. Does that make sense to you? The word minimal inhibitory concentration. Okay. So, the combination of Kirby-Bauer test, or disc diffusion test, and dilution test is so-called E-test or E-strip. You can see it here in the picture number 4. E-strip is a piece of paper that is infused with antibiotic, but the concentration of antibiotic in the paper changes from very high to very low. When you place it on the bacterial lawn on the plate, which, as you can imagine, is very easy, just take the strip and put it on the lawn, you can see the inhibition zone. And inhibition zone will give you minimal inhibitory concentration of a given antibiotic. Does that make sense? Before we move on to therapeutic index, what you have to know, what you have to understand is the difference between advantages and disadvantages of dilution test, E-strip, Kirby-Bauer test. What is minimal inhibitory concentration? And which tests allow you to determine that? Okay, Kirby-Bauer doesn't, others do. Now, what is the therapeutic index of a drug? It is applied not only to antibiotics, to every drug. So every drug has an ED50, effective dose, that treats the disease, cures the disease in 50% of treated population. Does that make sense? Do you understand why? So 50 is the acceptable form, okay? ED50, 50% of the population. Every drug has a toxic dose. Toxic dose, TD50, is the dose of the drug that kills 50% of the treated population. Which one should be higher? Huh? So again, TD is toxic dose, ED is effective dose. Which dose should be higher? Toxic, of course. So your effective dose should be lower than the amount of drug that will cause toxicity. Great example is Tylenol. You take 10 mils of Tylenol, you're going to reduce your fever. You take the full bottle, drink it down, you kill your liver right away. Okay? Now, therapeutic index is the ratio. It's TD50 divided by ED50. So effective drug should have therapeutic dose more than 1 or less than 1? More than 1, right? Because toxic dose is more than effective dose. Essentially, therapeutic index cannot be less than 1. Because if toxic dose is so low, you will never know what the effective dose is. Your patient will die first. Okay? Now, what is better, the big therapeutic index or the small therapeutic index? The bigger is the better, because it gives you more leeway, you know? If you have therapeutic index of, say, 1,000, then you can pretty safely increase the effective dose, maybe even 10 times, and still be way under the toxic dose. Does that make sense? I love the example of one drug that was used to treat some parasitic disease of horses. It was an experimental drug. The company designed it, and they decided to, so clinical studies in horses. And they give it to a horse, 1 injection. And all symptoms of parasitic disease just go away. It's extremely effective. So they'll celebrate, next day the horse dies. So this drug had therapeutic index of 1. Effective dose was equal to toxic. Okay, you don't want that drug. You want the drug with a large therapeutic index. So you can expect the question about therapeutic index. What it is. If I give you toxic dose and effective dose, you have to be able to calculate therapeutic index. I'm not going to give you crazy numbers. And you can use calculators. Okay? Any questions? All right.